Yeah. Well, of course I know who you are, Caroline. I just need to see your last name, then it clicks. There's a lot of Carolines out there. So thanks for everybody hanging in to the end of the day. And I hope I just don't disappoint, but and it may not go the whole half hour, but there's a few things that I just want to convey to you that I think are kind of important little tidbits that may put perspective on some of the things you heard earlier today. So first of all, just a word about our triage criteria. So determining whether a patient goes to the trauma bay is a decision that's based on criteria that have been developed by Maryland State, by DC, the DC regulators, and by the American College of Surgeons. And we have three levels. We have the standard level, we have the attending level, and we have the transfer level. And the attending level is the level where we have the most people assembling and the most need. And the transfer is where we have the least amount of people assembling. And I think that the key thing to understand here is that even though these levels are not, just because a patient gets triaged doesn't mean that they're going to be admitted to the hospital. In fact, most of the patients who come to the trauma bay are not admitted to the hospital, and we're not unusual. If you go up to shock trauma and you look at who comes to their version of an emergency room, the majority of patients who go there go home. A significant number of patients then go home. So this under and over triage is not a unique problem that we have. And you really want to make sure that you don't miss patients who have serious injuries. And if you get the information from the scene, it's really pretty rudimentary. You may just have some basic information about the mechanism. Maybe they had an LOC, maybe you have a few little tidbits like their blood pressure and pulse and things like that. And so we necessarily need to have a lot of patients go through the trauma bay who are minimally injured in order to deal with our under triage rate, which is to make sure that if a patient has an important injury, that we don't miss it. And we have some discretion about how we word and manage the triage guidelines, but a lot of that is mandated. And we realize that this is not a perfect screening process. And if you understand that, I think it will help to understand where we're coming from with what we do. Figure out how to do. I'm doing this like double remote. Okay, so CPR. So when a patient comes in full cardiac arrest in the trauma bay, there's a lot of panic, a lot of confusion, and I think that if I kind of like, well, we're all kind of calm, cool, and collected, can give you my perspective on what we need to do, I think it will help us to understand better how to work as a team. So first of all, if a patient comes in after injury with CPR in progress, you need to ask some basic questions in order to determine what's best for the patient. One of the first things you need to do is to see if the patient has signs of life. And here I have listed the signs of life: pupils, ventilation, pulses, blood pressure, movement, cardiac electrical activity. So one of the early priorities is determining if the patient has signs of life, because if the patient has no signs of life, then that's not good. If they have signs of life, then that patient is a patient we need to be considering about opening their chest or doing some other things in order to save their life. One of the key questions you got to ask is how long it's been going on. So when a patient comes in CPR, I like to say, how long let's do the signs of life. Let's get an best accurate assessment of the duration of CPR and see whether or not we should continue. So if a patient has had more than 10 minutes of CPR, whether it's a blunt or penetrating mechanism, the chance of that patient surviving is essentially zero. It's essentially zero. Penetrating patients do better because those are patients you can actually open their chest and do something about if they have a chest injury, or sometimes if they have an abdominal injury. So if a patient has no signs of life, the patient's duration of CPR has been confirmed to be greater than 10 minutes, certainly more than 15 minutes, then you're done. This patient has no meaningful chance of surviving. And if the patient survives, at best, the patient will be an organ donor. And I think that there's a concept that we need to do everything. And I absolutely agree. We need to do everything. But everything doesn't mean taking a patient who is non-survivable, who CPR and all efforts are futile, and continuing to do, put chest tubes in, give medications, do chest compressions, open their chest for minutes and minutes and minutes, and 30 minutes, 40 minutes, 50 minutes. You know, you're not doing anybody a service. And in fact, there's good evidence that we're doing ourselves a disservice by prolonging something. And I think that our focus should be when the patient comes in is get the facts. Get the facts. What are the facts? What are the signs of life? How long the CPR has been going? And act based on the facts, and move on. Epinephrine is a great medication, but it's interesting, if any of you have worked in an adult trauma bay, epinephrine is not very commonly used, but we frequently use it. So I think that this slide has a simple message that I want to get out to everybody. If you're using epinephrine in a trauma patient, you need to be asking yourself, are you not doing something else? And that something else is transfusing the patient or treating some injury that can be treated. Because trauma patients don't die from lack of epinephrine. Trauma patients die from bleeding. Trauma patients die from asphyxiation from airway that's not managed. Trauma patients die from a devastating head injury. These are the things that patients die of. And epinephrine, if you're given, so nothing wrong with giving epinephrine in the right context, but if you're given epinephrine, the first thing that should come to your mind is, why aren't we doing something different that actually can save this patient's life? In particular, why are we not giving fluid? Why are we not giving blood? So it's a question we need to ask. And again, a lot of these things are my kind of free association as I put together the comments that I wanted to make. Okay, so we really want the patient to get a manual blood pressure when they arrive in the trauma bay. And we even saw this in a recent video review where the team put on a automatic blood pressure cuff and pushed a button on the monitor to try to get the blood pressure. And there's a specific reason we want you to get a manual blood pressure first. Why? It's faster. It's simply faster to get a manual blood pressure. So we did a video review study where we looked at how long it took to get a manual blood pressure and how long it took to get an automatic blood pressure. Manual blood pressure is a few minutes faster. So this is, and also it's you know, cuff size problems can mess us up. And I think you have less of these kind of problems when you're doing a good old fashioned manual blood pressure. And I get it. It's easy to put a cuff on and push a button. You got a lot of things going on, but it's a key part of the initial evaluation. Really want it to be done. Starting IVs. So when a patient, so we have found so many problems with delayed IV starts. And delayed IV starts, it messes up a lot of different things. First of all, IV is a portal to draw blood. IV is a portal to give fluid, to give medications. So clearly, if you're having trouble starting an IV, then you're delaying those things. But we've also seen that patients have multiple repeated attempts to start an IV, trying to meet the sort of paradigm of you got to have two big IVs when the patient has other more pressing needs, and the IV should be given up on. So I think that it's a great idea to have two IVs, especially in a sick patient. But sometimes in a sick patient, we need to move their care along, and one IV is good enough. And realize when you're starting an IV on a patient in the trauma bay, it's a very common cause of delays in care. And so make sure that your efforts in that regard are shared by the team, that this is also a team priority. And then IOs. IOs should be the strategy intraosseous line should be a priority in patients who have a prolonged attempt at IV placement. And let's see if we can. Okay, GCS, the Glasgow Coma Score. I have a few comments about this. First of all, nobody's good at it. Everybody thinks they're really good at it, but they're horrible at it. And it's one of these things that, okay, you guys learned some things today. Maybe GCS was part of what you learned. Maybe you learned it before. Everybody sort of expects you to know it. And the reality is people often don't know the nuances of things they don't do. And so what I recommend, and we strongly recommend, is you cheat. I like cheating. And so what we did was in the trauma bay, we put the GCS table of what the motor and the verbal and the eye component are right above the bed so the resident can look at it. And we encourage them to look at it and call out what the scores are. And the reason I do that is I don't want the residents to be embarrassed for them to say, listen, I have no idea what I'm doing when I'm doing a Glasgow Coma Score. I want them to cheat. Glasgow Coma Score, by the way, we discovered in several of our studies is incredibly important in predicting patient outcome, and not in the way that you would think about it immediately. It's not just because it means if your score is low, you have a bad head injury. It also means when your score is low, and your score can be low when you're bleeding. So a patient who comes in with a gunshot wound to their chest with a low GCS, that is bad. And it's not because there's anything wrong with their head, except there's no blood going to their head. And don't forget, in the motor component of the GCS, people will often stand away from the bed of this patient who's not responding and make some declaration about what their movement is. In order to elicit movement, you ask people to move, you elicit pain. That's how you actually get the Glasgow Coma Score. Oops. RSI medications. Cindy, you guys talked about RSI medications today?
We did not. We've been like more like hospital focused, not just the trauma bay.
So in the trauma bay, we give, if a patient needs to be intubated, we have a smorgasbord of RSI medications. And the medications we give are etomidate, succinylcholine, and atropine for patients who are less than 5. And the reason that we established these 3 medications is that we observed in video review that when we left this to an a la carte approach, is it wasted time. And so what happens is the people would stumble to try to look for the medication they didn't have. They would have discussion about it. People would be confused. So what we did was we had this multidisciplinary vetting process where we went through all the possible medications for RSI and came up with the medications we use. And so we really encourage people to not go off script. And why not go off script is because this is a pretty good strategy. It's not like it's something like we casually thought about it. And when we do a video review, we see that people take longer to intubate when they start doing a la carte medication. So standardization really, truly helps. Hypertonic saline. So when a patient has a bad head injury, there's a lot of different things that you can do to make them better. You make sure that they get oxygen. Okay, of course, you do that for every patient. Make sure their oxygenation is good. Make sure their blood pressure is good. Okay, but there's some other things that you do. You want to put their head up to reduce their intracranial pressure. You want to maximize their cerebral perfusion pressure. All these maneuvers. One of the maneuvers to do is to give hypertonic saline, and hypertonic saline reduces intracranial pressure. We have this hyperosmolar therapy protocol that we developed probably now 12 years ago, and we revisited it recently, where we came up with the criteria for when you should use hyperosmolar therapy, when you should give 3% saline or mannitol. These are basically the 2 types of hyperosmolar therapy. And the key thing that I want to emphasize is that here's the criteria that we want to use. And these are criteria that have been vetted with the ICU, are consistent with the literature that's out there. are more or less vetted by the ED guys. And I say more or less because every once in a while we have somebody comes in and goes off script. And basically, you shouldn't begin a hyperosmolar therapy unless you have a Glasgow Coma score of 3 and you have fixed and dilated pupils, 1 or 2 fixed and dilated pupils. So suppose you have a Glasgow Coma score of 9. Is hyperosmolar therapy something you should do? The answer is no, you shouldn't. And well, why not? What the heck's wrong with it? Why not just do it? Well, one of the reasons is that we found that when people give it when it's not needed, that it just wastes time. So we've seen patients who are being intubated who need to get oxygen because of their head injury with a GCS of 9, but instead that intubation is delayed because somebody's starting an IV or having a discussion about hypertonic saline or something like that. So just so that our team knows that hypertonic saline is a great medication, but we want to give it to the right patient. I think that Zach talked about this earlier about what the delays are. Let me just say that the blood refrigerator, which is I guess broken today, sadly, but will be fixed, I guess. So there's lots of different things that go into transfusion delay, and I think he talked about this earlier, right, Cindy?
Yes, he did.
Okay, so I'll skip by that. Okay, crowding. Everybody. So there's 2 things that get everybody down in the emergency room in the trauma bay. One is free donuts, and the second is a patient with a penetrating injury to the chest. Those are the two ways you can really get a good assembly of people. And so crowding is a real problem. And one time we did this study where we counted the maximum number of people walking in and out of the room in a given trauma resuscitation. And we get numbers like 50, like huge numbers. And those 50 people each believe they're doing the right thing. They believe that by going into the trauma bay that maybe they're going to be in the CPR line. Maybe they could offer to help out somebody. Maybe just by being there, they could be an inspiration to the team, something. Well, the reality is that so this is a study we did where we looked at the average number of people around the bed and then looked at the performance of the team. And not surprisingly, if you only have one person working in the bagel shop and a crowd comes in, the service is going to be bad. But now suppose you have 50 people working in the bagel shop. Now the people working in the bagel shop can't even get the bagels at the counter. And so performance of the bagel shop starts to fall off. And that's what happens in our trauma bay. When you have very few people in the trauma bay, performance is less good. But as you go up, this is this bell-shaped curve you see on the right. As you get more people, it sort of optimizes, but then after a while, performance starts to decline. And if you're in there and you don't have a purpose and you don't have a role, then you're contributing to that decline in overall team performance. Now, teaching is important, and we understand that you got to learn somewhere. But if every role has a trainee, then suddenly the team size doubles. So I think that if everybody has the view to say, do I have a reason to be here? Do I have an assigned role? Or am I just a person that's looking for a free donut? Hang on. Okay. C-spine clearance. I just have a few things about this. First of all, there's no such thing as clearing the collar. You hear this all the time. People say, I cleared the collar of the patient. Well, you know what? The patient's cervical collar is totally fine. We don't have to clear it. There's no broken collar. It's the neck we have to clear. It's the cervical spine. So the term everybody should use is clear the cervical spine. Clinical clearance is something that we very commonly use in the trauma bay and on the floors. You guys will see this. And that's where you do a neurological exam. You assess the patient for tenderness and for pain with active motion, you can clear the spine, not clear the collar. We really try hard to reduce the amount of radiation exposure to kids because of pretty good indirect evidence that radiation exposure to the neck increases the likelihood of malignancy in kids. And so we were really pretty crazy about this. So we only use plain films and not CT as the initial screen. And then every single patient who gets a CT scan of their neck for any reason whatsoever, we do a PI review to make sure that that was indicated. And when it's not indicated, we provide that feedback. Now, if you're at an adult hospital, it's completely different. You get a head CT, you get a neck CT. They're like hand in hand. We don't do that. There's no, we don't do Me Too CTs. And we look very careful at this. And this is a good area to avoid radiation. If you haven't seen the PCARD head CT rule, here it is. This has been around for a long period of time. It really is a great tool. And it basically asks a few simple questions: how old the patient is, some questions about their neurological status, some simple questions about their mechanism of injury and their physical examination. And this is a great screen to help us to minimize the use of CT and to get CTs done when it's needed. So if you're not familiar with this PCARN rule, it's probably worthwhile to look at it. It's really quite effective in practice. We use, and I think this may be my final slide here. So, we have, I think Zach talked about, you can nod, Cindy, Zach talked about video cameras and things in the trauma bay. So when I came to Children's National, there was kind of a video system that I think it was recording to VHS tapes or something like that. And you can see when you go down the trauma bay, well, they may not be there anymore, but there used to be these things that look like these big, it looked like a clear, dark bowl that was like plastered to the ceiling. And that was the video review system. Nobody was really kind of using it. And we installed a system that now, if you purchase that system for video review with all the cameras we have, would probably cost you $35,000 to $40,000. And the cost of it has to do with the quality of the cameras, the cost of the installation, the fact that this goes onto a server, the software to manage all this, the software on everybody's computer to look at it. And so when I came, we put this video system in for two purposes: for quality improvement and for research, and really in some cases, sort of the combined effort of quality improvement and research. So video review, if you haven't been to one of our video reviews, and maybe because you work in the OR, maybe you work on the floor, you should come to one of our video reviews to see how we look at patients' care in the trauma bay, and how we really look for, try to identify what people do right, because people mostly do things right and rarely do things wrong. But looking at it when they do things wrong, how can we as a team come up with a solution that we can implement so that the next patient gets better care? And so the video system that we have now has been updated probably now 3 times since we first installed it. We don't use it for punitive purposes. So if somebody comes to me or Jen or Cindy and says, hey, listen, John was mean to Sally, or Sally was mean to Sue, or whatever. What we do is we don't say, you know what, we're going to go to the video, get the evidence that this meanness occurred, and let their supervisor know. Instead, what we do is we look at the video, we look at how people are interacting and try to understand what the confusion was about, what the issue was, and try to understand. Almost every single time when we get some kind of concern about people's behavior in the trauma bay, when we watch the video, it's not obvious. You can't see it. And it's not because we don't have good cameras and we don't have good audio. We do. What happens is what people's perception is after seeing on a videotape is completely different from what happened. And so almost always, and I would say almost it's pretty unusual. Almost always, the conflicts that people claim that we see, that they occurred don't occur. And I suspect if we put a camera in all the clinical areas that you guys worked in, and then recorded what was perceived as some kind of clinical conflict with somebody, I think you might see the same thing. So a lot of this clinical conflict is situational. People are stressed out. They have different priorities. They perceive that other people are intending to do something or saying something that they don't agree with. In reality, it often doesn't happen. We don't use the videos for research purposes unless we have patient consent. We do have permission to use the videos for quality improvement even without patient consent. And that allows us to really look at the processes of care in a meaningful way. A lot of centers around the country can't do video review. Their attorneys are barriers to it. They don't have as forward-thinking attorneys as we have. And so I think this is, and we really respect that this is a privilege that we're able to do this and really treat it with that framework rather than use it as a tool to get back at people or punish people or to find what people are doing wrong. We want to use it as a tool to make things better, and I believe that we've been successful at that. And I think, Cindy, that's it. And I'm a couple minutes ahead of time, but maybe I can answer any questions if anybody has any questions. And thanks for joining us today, guys. Really appreciate it.